Thanks so
Okay.
much, Kathy, for that kind introduction. And hello, everyone. I'm so honored to be here with you all. Again, my name is Hannah Diamond. I use she, her pronouns. I'm a policy advocate at Justice and Aging. And I'm really excited to be talking to you today about policy recommendations to increase equitable access to home and community-based services in New Jersey. So a little bit about Justice and Aging for those of you who might not know us. We're a national organization that uses the power of law to fight senior poverty by securing access to affordable health care, economic security, and the courts for older adults with limited resources. And we've been doing this work since 1972, and our efforts have been primarily focused on those who have been marginalized or excluded from justice, such as women, such as people of color, LGBTQ plus individuals, and people with limited English proficiency. And before we begin, I just want to share our commitment to advancing equity. So to achieve justice in aging, we must advance equity for low-income older adults. We must address the enduring harms and inequities caused by systemic racism and other forms of discrimination.
This? No. Is it
And we
this?
must recruit, support, and retain a diverse staff and board. Okay, so some objectives for today's presentation. We're going to provide an overview of Medicaid long-term services and supports. We're going to describe the home and community-based services infrastructure in New Jersey. We're going to highlight some examples of inequities in New Jersey using Justice and Aging's home and community-based services equity framework. And then we're going to talk about some equity-focused strategies to dismantle inequities in New Jersey. And this is a really good session to follow the previous one, where we talked about and identified some inequities like lack of prompt coverage for specific providers and like the asset threshold concerns that were noted by the ALP providers. So what are Medicaid long-term services and supports? There are two categories of services. An individual can receive care in an institution, like a nursing facility, or they can receive care in the community. And these services are called home and community-based services, or HCBS for short. So these services can be provided in a private home. They can be provided in a residential care community, most commonly known as an assisted living facility or a group home, or they can be provided in non-residential settings like adult daycare centers. So what is the purpose of home and community-based services? They're really aimed at supporting the independence of the individual and also to help the person integrate into the community. So I have here on this slide some examples of home and community-based services in New Jersey. This is not an exhaustive list, but just some that I wanted to highlight for you. Personal care services, care management services to help someone navigate the complexities of their care, home and vehicle modifications, home delivered meals, respite services. This is a really big one to support family caregivers. PERS, the Personal Emergency Response System service that notifies an individual or notifies or contacts emergency services when someone falls. Mental health and addiction services, assisted living residents, the ALP program, incredible program that you just heard about, and community residential services and adult daycare services. So who pays for long-term services and supports? Many people think that Medicare, which is a federal program that provides insurance or coverage for individuals age 65 or older, or for people with disabilities, with qualifying disability benefits, or for those with specific conditions such as end-stage renal disease. Many people think that Medicare is going to provide coverage for long-term services and supports. And the reality is that Medicare covers very limited long-term services and supports. It will cover a nursing facility stay for a set period of time, but it has to be, previously someone has to have a qualifying hospitalization.
Diagnosis.
And then there are limited personal care coverages through a home health benefit that are enabled through Medicare, but someone needs to be homebound or meet that homebound definition. So Medicaid is the primary payer of long-term services and supports. Medicaid is a means-based program. So this is this means that someone needs to be very low income in order to qualify. I will note that it is a federal and state partnership. So the federal government provides basic parameters for the Medicaid program, certain populations that need to be covered, for example, certain services that need to be provided, but then states have extensive flexibility in the design of their Medicaid programs. So who are the population that we're talking about here? I am talking about primarily people who are dually eligible for Medicare and Medicaid. And there are about 220,000 of these individuals in New Jersey. And I want you to note on the left-hand slide, I have the left-hand side of this graphic, I have the demographic makeup of people dually eligible. And you can see that they're more diverse than the Medicare-only population. They're more likely to have a chronic condition. They're more likely to have limited health literacy, and they're more likely to be LEP, limited English proficiency. So when we're thinking about equity when it comes to home and community-based services, we need to be thinking about policies and programming that meet the unique needs of the population that we're talking about. So how does someone receive long-term services and supports in New Jersey? An individual can receive services through estate plan benefits. These benefits include medical benefits, home health care, medical daycare, personal care assistance services, and there are various pathways for individuals to access these services. And I want to note as a takeaway that each pathway has different financial eligibility criteria associated with it, which results in coverage gaps as individuals navigate these various pathways regarding eligibility. And then if someone needs more extensive services beyond state plan benefits, they would receive these services through managed long-term services and supports. So these services are provided by a managed care organization or insurance company that the state subcontracts with. And an individual must meet specific clinical and financial eligibility criteria to access these services. I just want to let you know that in New Jersey, the managed long-term services and support, so both HCBS and nursing facility care, are covered under a waiver called the 1115 waiver. This is a demonstration or experimental-based waiver that allows the state of New Jersey to really be innovative in its design of home and community-based services and long-term services and supports in general. So this gives you all a lot of flexibility to be creative in the delivery of your services and address some of these inequities that we're going to be discussing. So first I want to talk about the institutional bias, and this came up in the previous session. So going back to 1965, Medicare and Medicaid were created. They were created as two distinct programs that were never really meant, unfortunately, to work together. And Medicaid law from that time required coverage of care in an institution, in a nursing facility. But unfortunately, to this day, federal law does not require states to provide the full range of home and community-based services that people need. So an individual that is in need of long-term care services is only guaranteed care in an institution as opposed to in their home, in the community. And we have seen efforts over the years to rebalance funds away from institutionalized care and towards community-based care. There is a really significant Supreme Court case called the Olmstead v. LC case. This case found that the unnecessary institutionalization of individuals living with disabilities violates their rights under the Americans with Disabilities Act. And since Olmstead v. LC, we have seen federal and state efforts on behalf of policies, guidance, funding to rebalance funds and help move people away from institutionalized care and towards the community. But unfortunately, our system is still rooted in this institutional bias, which is fueled in part by ableist and ageist beliefs that individuals of those communities belong in an institution as opposed to aging independently in the community. And so the changes that we've had over the last few decades and the wins that we've had have been incremental, but we just need to remember that the system itself is built on this institutional bias. So now I want to introduce to you our equity framework. This equity framework is really meant to be a conversation starter, a tool for you all to think critically about how inequities are embedded within HCBS infrastructures. Sometimes various policies that are either racist, ageist, ableist, or discriminatory in various ways are obvious. So the institutional bias that I mentioned previously, or redlining as another example, or there's another terrible policy called Medicaid estate recovery, which we could talk about. Those are very obvious. But sometimes even seemingly neutral policies and program rules can perpetuate inequities that results in disproportionate burdens of poor health or inadequate access to services amongst particular populations. So this tool, again, is really meant for us to put on our critical lens, our critical hats, and think about how particular design decisions are impacting various populations. So our equity framework has 5 domains, which we're going to be talking about. And again, when we're thinking about how a policy impacts particular populations, I want you all to be thinking about the impact on older adults, on people of color, on Native populations, on women, on LGBTQ+ individuals, on people with limited English proficiency, and people in various geographic locations, whether or not that's urban or rural settings. And then I also want you to think about how intersectional identities can compound and result in insufficient access to various services. So there are 5 domains, and we're going to be covering each domain, and then I'm going to give you a New Jersey specific example of what that inequity looks like. So the first domain is program design. This is really encouraging us to think about who is eligible for services, where are these services available, and what services are offered, and more importantly, what services are not offered. The next domain is provider availability. So here we're thinking about network adequacy, we're thinking about reimbursement rates, we're thinking about opportunities to really engage in that retention piece for workers so that the recipients of these services can have the highest quality care possible. The next domain that we're thinking about is program awareness and enrollment. So here we're thinking about how is the state communicating about these various services, and is this process accessible to individuals? The fourth domain has to do with the assessment and authorization of services themselves. You know, assessment tools were created by humans with biases, and the humans delivering these services have biases. So how is that contributing to insufficient access? And then finally, we're analyzing the services themselves. Are they person-centered? Are they accessible? And are individuals with lived experience engaging in the oversight process? And then I have a note here that data collection and reporting are key to transparency and oversight across all domains. So I want you all to think about data really being woven into each of these 5 domains as opposed to a separate bucket, because we need that information in order to develop tailored strategies to meet the unique needs of the populations that we're talking about. So the first is program design. So this is the thresholds that examines the initial design decisions that a state is making regarding its HCBS infrastructure. So I mentioned earlier that New Jersey is providing these services in 2 ways, through a state plan or through its 1115 waiver. So a state plan has to be provided to all individuals who are eligible for services. While services that are provided through a waiver, states can put caps on enrollment, and states can limit it to particular populations, and states can also have wait lists for services. So that's just an initial design decision that might limit access. Something else that I want to note, does the waiver authority limit the level of care criteria for who can participate? This is a real problem that we see within the HCBS waiver landscape. There is a cost neutrality requirement with many HCBS waivers that says that basically the cost of services provided to an individual cannot be more costly than care provided in a nursing facility, which means that for those with the highest needs, perhaps home and community-based services may not be accessible to them because of this cost neutrality requirement. Community engagement, where people with lived experience consulted and engaged in the design process. When I ask this question, for the most part, the answer is no, unfortunately. There are very basic requirements for community engagement within Medicaid, but I would challenge us to think about whether or not those community engagement experiences are meaningful. Are individuals being paid to contribute their expertise? Are there allocated funds from the state to ensure that there are accessibility requirements in place to provide individuals, with the ability to participate and the information that they need to participate in a manner that is accessible to them? These are all things that we really need to be thinking about. Regarding program benefits, which services are included, and as I stated before, which services are excluded? For example, New Jersey has a respite benefit for its caregivers. I encourage you all to think critically about whether or not this respite benefit is sufficient to support family caregivers with their needs. And then the next point regarding a waiver wait list. Does the state have a wait list? And what is the process for moving people off the wait list and advancing to services? Is it on a first come, first served basis, or is it by priority? And how is the state defining priority? So now I want to spend some time talking about eligibility criteria for NJ Family Care. This was mentioned in the previous presentation. I think, Dorothy, maybe you asked this question, and so I hope to answer it now. And I just want to give us a little bit of background and context. So the Affordable Care Act enabled states to expand Medicaid eligibility to populations under the age of 65. So these populations, if the state is engaging in Medicaid expansion, this is called the MAGI population, they can qualify for Medicaid with an income of up to 138% of the federal poverty line. This population is not subjected to asset restrictions. So unfortunately, the Affordable Care Act did not expand financial eligibility criteria to older adults and people with disabilities, which means that the population that we're talking about is subject to more stringent criteria than other populations. So let me show you the impact of that. So for example, when an individual turns 65, through no other changes in their circumstances other than they turned a year older, they could lose their Medicaid coverage because all of a sudden they are subjected to more stringent income and asset criteria. And I'm going to show you what those are in the subsequent 2 slides. And then what is the impact of this? When we have really limited thresholds of $2,000 or $4,000, depending upon the pathway to access benefits, it forces these populations into deep poverty, which inhibits their ability to save for an emergency, like a leaking roof or like a car repair. And we see that there is a disproportionate impact on particular communities, specifically older adults of color, who are more likely to be renters and have cash than homeowners. For Medicaid eligibility, your home is an excludable asset as long as you're living in it. But if you're a renter, you have to save for first, last, and security, for example. So this is disproportionately harming particular communities, specifically older adults of color. And overall, these policies are really reducing the health and financial stability of the populations that we're concerned about. They result in coverage gaps as people navigate various pathways. So here's what it looks like when it comes to income. So I have here the Medicaid expansion population. This is the younger cohort, so cohorts that are younger than 65 or not disabled. They can have an income of 138% of the federal poverty line, which in 2024 is $1,732. The age-blinded disabled population, this is for state plan benefits. So this is, again, older adults and people with disabilities. They are subjected to an income threshold of 100% of the federal poverty line, or $1,255. So you can see there's about a $500 gap here. So someone who, again, is turning 65 or someone who is becoming Medicare eligible is likely to lose their Medicaid. because of these really strict criteria. I'm going to show you another example when it comes to the asset thresholds. So here are the asset thresholds for various programs that are impacting older adults and people with disabilities. So you can see here's our MAGI population, our younger population. This population is not subject to asset thresholds. New Jersey also has expanded this protection, so has eliminated asset thresholds for its working disabled population that receives coverage through NJ workability. So there's already precedent here in the state that we can build upon. Then you can see for our ABD benefits, our state plan benefits, there is an asset threshold of $4,000. For our managed long-term services and supports, there's an asset threshold of even less, $2,000. So you can see it's very difficult for individuals to understand because the criteria is so different. They're likely to fall in the cracks in between these various pathways as they navigate them. It's difficult for the state to administer because it's difficult to explain. So there's a lot of challenges associated with the current eligibility criteria. I want to flag the JAC program for you all here. This is known as the Jersey Assistance for Community Caregiver Program. This is a program that provides access to basic long-term services and supports to individuals who are over the income or resource threshold for NJ family care programs. I'm just flagging this for you all because it's $40,000, and you're going to see this in our proposal on the next slide. So what should New Jersey do? How can we fix this, right? Basically, there's a twofold fix, and there's a lot of excitement around specifically the asset eligibility criteria proposal, which I'm going to explain. When it comes to income, we want to align with the younger cohort, align with the MAGI population. So increase the age, blind, and disabled threshold to 138% of the federal poverty line so that someone's not losing their coverage just because they turned a year older. And the same thing when it comes to assets. We want to create continuity across these various pathways, and we don't want individuals to have to impoverish themselves. So we are proposing for the programs that impact older adults and people with disabilities to align with the JAC program, so to increase the threshold to $40,000. So this will enable individuals to have a little bit of money, very little bit of money to save for a rainy day. It will enable individuals to not lose coverage as they navigate various pathways, and it will enable increased access to home and community-based services, all really important policy proposals. And I will say that specific to the asset threshold piece, there is quite a lot of energy and excitement around this proposal. New Jersey Advocates for Aging Well is engaged, AARP New Jersey, Leading Age New Jersey and Delaware, the ALP providers, some supportive housing folks. So we would love you all to join us in our efforts. This can be accomplished through the state budget process or through legislation, and we are actively engaging in conversations to try and advance these proposals. So the next bucket is provider availability. So here we generally find that network adequacy standards when it comes to managed care and home and community-based services are inadequate. So the first question is, does the state have network adequacy standards? And are these standards maintaining the status quo, or are they perpetuating racial segregation? And are they meeting the needs of particular populations that are receiving these services? We often find sometimes, especially in the HCBS space, that states don't have adequate oversight opportunities to even get at what a network adequacy requirement would be for particular types of delivery models. So this is a key area. When we're thinking about provider reimbursement rates, we're thinking about who can participate in the first place. You heard all of the barriers from the ALP provider presentation earlier that prevents kind of growth of that program. So which providers can and cannot participate? Is it just favoring those who are well established? Or is it allowing smaller providers who are more culturally, perhaps more culturally competent, more representative of the community? Is it allowing those providers to participate? And is it allowing workforce investments in those reimbursement rates? We really need workforce investments in order to retain a high quality workforce that can cater to the needs of the populations that we're discussing. And when it comes to caregiver supports, again, I ask you to think about, are the services that are being provided by the state sufficient, and what other resources do caregivers need? So here is another example of inequities. This is specific to the assisted living residence program in New Jersey, which makes the case for even greater expansion of the ALP program that you heard about earlier. So basically on this slide, you will see that I have the counties that have the most older adults, and I have them grouped by more racially diverse or less racially diverse. And what we find is that the assisted living residence program is more likely to be in a location that is less diverse. And this is consistent with national data that finds that assisted living programs or facilities are located disproportionately in higher income and less racially diverse counties. So we really, again, need to be applying a critical lens. This is another great point to advocate for ALP expansion to remedy this fix or this inequity. The next piece that I want to talk about is program awareness and enrollment. So I ask you all to think about, as anyone who's ever navigated the NJ Family Care website, I myself have, it's difficult to navigate. So I want you all to think about, is the information centralized? Is it searchable? And is it accessible? Many times, I've named a bunch of different programs names. They often have nothing to do with Medicaid. They often have nothing to do with HCBS. So to someone who doesn't have insider knowledge, can they navigate it? Is this information translated into languages that are accessible for individuals? What winds up happening is when this information isn't centralized, or when it's not available in a format that is accessible, it winds up benefiting those who are the most privileged, those that speak English, those that are competent in how to use a computer, those who have the luxury of time or are connected to other resources that they can ask. So we find that inequities inherently develop when languages or information is not centralized and easily accessible. The next bullet here is asking about enrollment activities on behalf of the state. Is the state conducting enrollment activities, and to whom? Which populations are they prioritizing in their outreach? And is the information that's being provided accurate? Sometimes we find that due to lack of funding, due to lack of training, and bias on behalf of these workers, sometimes the information that's being relayed is inaccurate. And then the applications themselves. If someone is able to locate the correct form, is it accessible to them? And what resources are available to help them with completing the form if they need it? Unfortunately, New Jersey, like other states, has had a very difficult time in the redetermination process for the public health unwinding. We have found that countless older adults and people with disabilities, the majority of the terminations for Medicaid benefits are not terminated because these individuals are not eligible for benefits. They're terminated because they didn't return paperwork. And we know that this population has a very difficult time with the paperwork. So what additional measures is the state taking to assist these individuals? So a New Jersey specific example, we hear time and time again from stakeholders that application processes and information about HCBS is very complex, and that resources are not accessible, and that the state should be targeting particular populations that are at greatest risk, such as those who are unhoused, those with limited English proficiency, and communities of color. I'm going to give you an example. The PACE model is a really incredible model that provides integrated care between Medicare and Medicaid. And we find that Black and Latino older adults are less likely to know about this program because they're less likely to have a connection with a trusted healthcare provider. So they're less likely to receive a referral in the first place. And this is consistent with national findings that find that people dually eligible who are more diverse are less likely to have a connection with a trusted healthcare provider. So the fourth domain, here we're really thinking about, again, the assessment and authorization of services themselves. So we're thinking first about the implicit and explicit biases that were used in determining eligibility for programs. So assessment tools are often comprised of an algorithm. That algorithm was made by a person with a bias, and the assessor themselves, whether or not they're aware they have biases. So how are those biases coming into place here? The level of care evaluation. So someone to qualify for managed long-term services and supports needs to meet a nursing facility level of care. So we find that particular populations are at risk of not meeting that level of care designation. So this is often because the assessor or the algorithm tool is not considering the unique needs of those populations. So this is especially prevalent when we're talking about those with mental health diagnoses, those with IDD, developmental disabilities, and those with aging related chronic conditions such as dementia and Alzheimer's, which disproportionately impacts Latino and Black older adults. And then once someone is found eligible for benefits, then they need to have their needs assessed so that a service plan can be developed. And inequities can arise in this case as well. And so we need to be considering what are the needs of that particular population, and are there certain populations that are not receiving access in their service plans. So here's another example. We heard in the last presentation about I Choose Home. This is a really incredible program that should be celebrated in New Jersey. This is Money Follows the Person program. Money Follows the Person program is a national program that helps individuals transition from nursing facilities back into the community. And I Choose Home has completed thousands of transitions over the years. And again, it's really, it's something that you all should be celebrating in the state. But there are inequities. When you stratify the I Choose Home transitions by the older adults, so by individuals age 65 and older, and by populations that are younger, we find that only a third of the transitions have been focused on older adults. This is not proportional to the number of older adults that make up nursing facilities. Nursing facilities in New Jersey are approximately 80% older adults. So we would expect those transitions to be proportional to the amount of older adults that are residing in those facilities. And actually, in a recent budget, there was allocated funding to transition the younger cohorts, the IDD cohorts, out of a nursing facility through this program, and that's wonderful. But we also need targeted funding to support the older adult population to transition out. And then our fifth domain here. I know there was a lot of information, but we're nearing the end. This is our fifth domain. Here we're really thinking about the adequacy and the quality of services that are being delivered. Who's defining what's adequate, and how are those services being monitored? Now, I'll let you know there are various populations in New Jersey when it comes to home and community-based services that do not have adequate eviction protections. We see this in the assisted living space and in the group home space. They should have eviction protections that are comparable to those that are receiving protections under landlord-tenant law. But unfortunately, various locations of residents in HCBS settings are not receiving those protections. So you have to ask yourself, what are the due process protections? What are the grievance processes that are protecting individuals? What are the quality measures? Are these quality measures that allow the state to demonstrate 100% compliance, or are they meaningful? Are they giving us information to make quality improvement policies and programs? And then, are these services language accessible? Can someone communicate directly with their provider? And are they culturally competent? And here I have an example that is not New Jersey specific. This is a national concern, that we see individuals, LGBTQ plus individuals, facing discrimination and often going back in the closet when they enter a long-term care setting out of fear for their own safety, which not only limits their provider choice, but limits the quality of services that they're getting if they can't be their whole self and if their provider doesn't know who they are and how they identify. It also puts them at risk of increased discrimination and harm. So we have quite a few New Jersey specific resources for you all. You can find our issue brief on the HCBS equity framework listed on this resource page. There's also a fact sheet that's a little bit shorter. And we also have a primer on home and community-based services that you can read more about with an accompanying webinar. And then we produced a New Jersey specific report with 22 recommendations to improve equitable access to services in the state. And then we produced a few subsequent reports, and I've included the ones that are specific to income and asset limits and thresholds, outlining the inequities within the financial eligibility process and what New Jersey can do to address those concerns and leverage lessons learned from other states that have successfully addressed the inequities or these inequities like California and New York. And then if you're not already a member of our network, please do sign up. You can receive resources on all things related to aging, not just health focused, but also housing focused, elder rights focused, social security focused. So really encourage you all to sign up. And then my contact information is here. And with that, I'm going to stop sharing my slide. And I hope to be able to answer some of your questions. Thanks so much for your time and attention.
Thank you, Hannah. We did have several questions in the chat, and I think you answered some of them, but I want to see if we can expand on some. So Donna Lissy asked, and Donna, if you want to unmute yourself and ask, you can, but she asked about how much this would cost the state to propose this, to removing the asset limit or raising it to match Jack, I think she means. Yeah. And what would specific funding sources be for that?
Thank you, Donna, so much for that question. It's a really good opportunity for me to tell you that actually with the way that we've proposed this asset thresholds policy suggestion to the state would achieve savings. We've proposed it encouraging the state to take advantage of a flexibility that would allow the state, after someone is initially found eligible for services, to not have to re-verify their income and assets. So actually, because of that cost savings from administrative simplicity, and because of increased access to home and community-based services as opposed to more costly nursing facility care, and because these services are also preventative, so we're going to be preventing unnecessary placements into a hospital, which are extremely expensive, we actually think, based upon our back of the envelope calculations, that the state would save millions of dollars, and we've calculated $15 million actually in savings.
And hasn't California seen those savings?
Yes, California has already achieved these changes. So they actually increased their asset threshold in 2 phases. First, they increased it to 130,000. And then they eliminated it, and then they eliminated the asset threshold entirely. And so we can look at their data based upon the amount of people that became newly eligible, and we've applied that to our cost calculations here in New Jersey. So it's based upon real-time data that we have from California, our analysis, which I think makes our case stronger for cost savings.
Thank you. That was very informative. Thank you.
Mm-hmm.
We have a request. Can you put your the last slide up again with your contact information?
Sure.
Hannah?
Let me put it
that
in
again.
the chat for you all.
Okay.
And I am a resource through the Henry and Marilyn Taub Foundation. I saw Julia. We are supported by the Henry and Marilyn Taub Foundation to do this work, and we are really a resource to support you all in your advocacy. So if you have questions related to Medicaid, to HCBS, please reach out to me. I'm so happy to meet with you all, and I'm going to put my contact information in the chat right now.
Josh Raymond, did you have a question? No, maybe not. Does anybody else have a question? I'm looking for raised hands. I think Hannah, you were very thorough,
Oh, good.
and addressed most of the questions. Julia, oh, Marilyn Mock, go ahead, unmute yourself.
Hi, Hannah. Thank you for this great informative presentation. I was wondering if you think down the road there would be any consideration to New Jersey tiering MLTSS services. We have a lot of residents in our building who don't need personal care, but they need assistance with IADLs. And the state would actually be saving money and doing prevention services if they gave people what they need at the time that they need it. So if you provide IADL services like cleaning, housekeeping, meal prep, you may delay their need for personal care, like assistance with bathing and grooming. And it would save the state money because they would provide less care, but more targeted care to people who need that kind of care at that time. I was just wondering if you think there'd be an appetite somewhere along the way for the state to at least give some consideration to tiered services.
Yeah, Marilyn, that's a really timely question, actually, that you bring that up. Well, first, I want to note that state plan benefits are available to provide a minimal amount of the HCBS services that you're talking about. And then if someone needs more expansive services, they can access services through MLTSS. But you're right that those services require a nursing facility level of care. And that if that care requirement differed or was lessened, that people could get access to more resources that might meet their needs. There's actually a proposal at the federal level. Energy and Commerce just had a hearing last week, and this is one of the few pieces of legislation that is moving forward, to everyone's surprise, in a bipartisan way to potentially lower the level of care requirements for HCBS waivers. So whether or not that moves forward at the federal level, I'm not sure, given everything that's happening in Congress. But I think that that is interesting to note. And I think that states are going to, if they're not already doing it through how they define nursing facility eligible, I think that states are going to try to take advantage of opportunities to increase access to lower levels of care if they can. So stay tuned for what happens to that piece of legislation in Energy and Commerce. We will update you. But it is an interesting proposal to think about, Marilyn.
Thank you, Hannah. That's encouraging. Thank you.
Mm-hmm.
And Dawn Penner, you have a question? No, she was raving at someone else. We had a question about how did the JACK program end up at its eligibility level without other programs going to that level with them? Why was it JACK alone that had the higher asset limit?
Yeah, I think that's a good question. I would expand that. Like, why does one program have a $2,000 eligibility? Why does one have $4,000? Why for Medicare savings programs are they $9,000? I would say that unfortunately, there has not been a lot of thought in terms of making sure that there is continuity across these programs. And again, this goes back to kind of well-intentioned policy making that might have negative effects. I think that sometimes people weren't thinking about the coverage gaps that results between these various programs. And I think when it comes to the JACK program, again, is for people who are over the resource amount, but there's a cost sharing requirement associated with that program, and the level of services that are available through the JACK program is pretty limited. So even though someone might be able to get some services, they're still very low income within that JACK program, and they're not getting the resources. Many are not getting the resources that they need. So again, I think that that's why we developed this equity framework, is to really encourage us all to be critical about design decisions and analyze and think about the unintended consequences.
We also had a question. Someone asked, where is New Jersey in expanding the PACE program?
Yeah, the PACE program is a really wonderful model, and unfortunately, it has not expanded in the way that everyone anticipated. And that's just not unique to New Jersey. That's a national concern. Enrollment in PACE is quite low. And so there have been, again, recent federal proposals to try and increase access to PACE. But I would say in general, PACE enrollment is smaller than we would like to see it, not just in New Jersey, but nationally.
Donna, do you have a question again?
Yeah, yes, hi. I actually have two questions. One is I'm a clinical pharmacist, but I'm also chair of my municipality's Board of Health Advisory Council. And we did a local health needs assessment, and one of the things that was identified is that the seniors were, or the older adults in our community, were not aware of services. Now, we have a very active office on county office on aging. I know that because I'm part of that as well. I was the past vice president, and I'm a member now when my term was up. And so what mechanism have you seen most effective to get the word out to seniors? Where we have a congregate senior housing, we're a public hearing in a couple of days, but still all of our efforts, and I'm in Somerset, so I'm in central Jersey, so I'm not a rural area, but nonetheless, there's a there's a divide between getting the word out to the people who need the services, and letting them know that the services do exist and can help them, but they just are not aware of it. And I'm not quite sure how to reach them, other than we have active, like I said, we have active office on aging. We have a lot of programs through the libraries. We have two senior centers, a township funded senior center and a county funded senior center. So we're very senior friendly, but still the word is not getting out. Any thoughts on that? And my second question was, I love the idea of the money follows a program person and all the transitions of care out of the nursing home into the community. But from a pharmacist's point of view, that's a very dangerous time, medication wise. And transitions of care, medication reconciliation becomes such an important focus there, because medications that should have not been used in nursing home, or that should have been stopped, inappropriate antipsychotics, so, a great example. How is that managed in the community? What kind of follow-up is there to make sure that that doesn't, that the medications are the appropriate ones now that they're in the community?
I thought it was a good one.
Okay, thank you. That's it. I'm sorry. Sorry for taking up so much time. Thank you.
No, that's good. Good questions.
Giving me hard questions, Donna. Okay, I'll do my best. Regarding information, I think it sounds like you are doing the right thing by relying heavily on your senior centers, which I think is great, and going to where older adults actually are. I think a few ideas that you might consider, if you haven't done this already, is really relying on community-based organizations and partnering with them to disseminate information. We find that community-based organizations are trusted sources of information amongst particular populations especially. I would include churches in that category. So really leaning on trusted sources as messengers of information. And we find that too often those groups are not included in critical health conversations, but they are a really key part of our social determinants of health that we need to be thinking about. And also, another thing, when you're sending out notices, I don't know about you, but I've received plenty of mail that I've never opened, unfortunately. And so I think we've seen during the public health unwinding, when notices are colored, for example, when it's a blue notice, when it's an orange notice, that denotes to the individual, hey, this is really important. And then also when that individual is talking, for example, on the phone to an enrollment counselor, that enrollment counselor knows what that orange or blue notice is. And so I think that we can be thinking about use of colored notices in that way. And then expanding this out even further, I would say you're just talking about initial information to inform someone about various programs, but once they're enrolled, there are best practices that we should be considering too. Like we can require all information, depending upon the delivery model, to be submitted to the state first for their review to make sure that materials are accessible. We can require beneficiary testing of information to make sure that they're resonating with their intention. So these are just all things that help to make the system more accessible.
And Hannah, I want to jump in and say, tomorrow, Sarah Manship, who has been our year-long policy intern, has done a great job analyzing our statewide survey of older adults. And one of the things that we found is that, yeah, there is a lack of information. And Sarah has started to pull that apart, looking at income level, people who are eligible for benefits, but are not aware of them. And we're also pulling out the differences in counties on how have people ever contacted their Office on Aging. And there's a range from like 20% in one county to 65% in another. So it's very inconsistent. We also asked people about where they get their information. So we're going to be pulling that together in our final report, because it does seem like one of the biggest issues is that people are just unaware of what is available to help them. And this year we're seeing, really big expansions in the eligibility for many New Jersey programs, for the PAD, the hearing aid, and the senior freeze and the property tax rebate programs. So we're going to be working on that over the next couple of months, because it was shocking to us, the just lack of knowledge, and we need to do something about that.
That's so great, Kathy, to hear about that work. And I would just add one other thing. There's been some recent rulemaking regarding the Medicare streamlining rule that should help to enroll individuals in low-income subsidies and various MSP programs that they might be eligible for, and that helps with Medicare cost sharing. So there are some additional requirements that are going to be put on the state for them to do some of that enrollment data analysis to see who is eligible and then outreach to those individuals. Donna, quickly to your second question, it's hard to answer because it really depends on not only the Money Follows the Person's program, but then also the delivery model through which someone is receiving their services. I would just note that your comment is very well taken and speaks to a limitation within our current system regarding lack of integrated care and the real need for an interdisciplinary care team to be working together to holistically address the needs of an individual as they transition throughout various care settings. And there are particular delivery models that do this better than others. In New Jersey, there's a model called a FIDE SNP. This is getting really wonky, but this is a model that delivers managed care services. So that model tends to be better in terms of performance when it comes to integration, but it's something that we should be striving to achieve for all individuals, regardless of the care setting that they're receiving services from. And we really need to be advocating for more person-centered planning, having the individual drive that process as much as possible, and have a really interdisciplinary care team that is partnering with that individual to help them meet their goals. So Donna, I hear you, and it's a great point.
Thank you, Hannah. I specifically like the idea of the interdisciplinary care team. I think that's so important, because nothing can be done when silos exist. It really does not benefit the patient. So I really like that idea. And is there any are there any plans to expand the program that you mentioned, or to duplicate that program?
Yes, actually, Justice and Aging is starting a 2-year education campaign focused on these integrated models, and we're working with 10 states across the country, one of which is New Jersey. So if you all want to find out more information about that project and opportunities to get more consumer protections within integrated models and really expand access to that type of care and some of the complexities that come with enrolling in that model, there are some limitations also. It's not the best decision for every individual. Again, reach out to me. Happy to talk about our work in that space and identify potential collaborations and partnership.
Great, we'll do. Thank you. Thank you very much for that.
I also want to point out Dorothy Sanders' comments in the chat on what worked so well during COVID on getting information out. We did it then and do it again.
Right, Dorothy?
Thank you for adding that, Dorothy. So we are coming up on our hour. I don't see any other hands up. Hannah put her email in the chat if you want to reach out to her, and I think you all know how to reach out to me. I can always connect you. I want to thank you, Hannah, for covering this. There's a lot of material.
Yes.
And if people are interested in learning more about aging policy, tomorrow in our afternoon breakout sessions, we have we're calling Aging Policy 101. And Maureen Henry from Columbia University School of Public Health and the Butler Aging Center is going to talk about aging policy at the federal level, while Ev Liebman from ARP New Jersey is going to talk about aging policy at the New Jersey level. So if you want to learn more about policy, how the sausage is made, that would be a great opportunity to do that. It's in the afternoon sessions that start at 1:30.
And Kathy, I'll send these slides to you so that you have access and you can share them with everyone who participated today.
Okay.
Thank you.
Well, thank you everybody for joining us today. We'll see you tomorrow. And again, if you have any questions, reach out to me or to Hannah. I will be sending you the reporting link and Hannah's slides for you to look at again. Thank you, everybody. Have a great day.